Okay, so welcome everyone to what is our 7th collaborative patient and public event from the DermAcademy here at St John's and with the National Eczema Society. And welcome everybody. Thank you for registering and taking time to join us. And so this evening's event is really focused on treatments beyond creams and ointments. And to access those treatments, people need to come and see a specialist in secondary or tertiary care. So we thought that, particularly since there's been so much development in this area, it was a good place to highlight what's new and what you might expect. And we've got 2 speakers and then a panelist with various expertise in children and adults. But the talks themselves and our discussion are primarily in the adult population, but many of the principles and approaches are comparable in children. And we have got a paediatric consultant dermatologist who's also deeply embedded in the research arena joining the panel discussion. So there'll be opportunity to raise those questions around children after the 2 talks. So just a few housekeeping rules before we start. Please do not video, audio record or take photos of any section of the event. You can see and hear the presenters and panelists, I hope, but we can't, sadly, see or hear you. But to ask a question relating to the presentations, use the Q&A bit on the Zoom, not the chat function because that's been disabled. And do post questions anonymously if you'd prefer. And we'll try our very best to answer them all. Often what we do is group them into themes because we often get the same questions asking around the same problem. The other part of this evening, integrated in the evening, is some opportunity to ask you about research and the future direction, because although there have been enormous advances in treatments for eczema, what we're interested now is can we develop better ones or use them in different, more effective ways? But we really need to ask you what you think, and so we have the whole problem properly encompassed and addressed in the future research programs that are being developed and funded. So I think that we should start, and if you would like to make a donation to support the NES, who are a fantastic society and really do provide an awful lot of information and support and work with us very closely on many things and research-wise as well as clinically-wise. So please do make a donation if you would like to. So I'm going to start now with our first speaker, and I'm very happy to introduce Dr. Leonard Timoney. He's a senior clinical fellow in medical education and medical dermatology here at St John's, Guy's and St Thomas's. He's passionate about educating us all, including me, and he's going to talk to us about what to expect when you come to see the dermatologist. Okay, thank you very much, Len.
Thank you very much, Prof. Smith, and welcome everybody. I will just get my slides up and running. So just bear with me a second. I just having trouble sharing it. There, sorry now. So let's okay. So I'll just ask first if people can. Okay, so I'll get started. So apologies for that. So essentially, I'm here today to kind of set the scene, and Dr. Pink will go into more detail about the different tablets and injections that can be used for eczema. But really, I want to go through what can you expect at your first dermatology appointment. So I'll cover a few things. I want to cover and maybe give you some tips on what you can do to prepare for your appointment. I want to go through the type of questions that we might ask you in the clinic appointment, so you're prepared to know what the answers might be. I also want to mention things that might happen to you in clinic. So who you might see, what examinations you might do, what tests might be done. And then finally, just a few tips on the information you can get before you leave. So really, I suppose you need to, eczema is a complicated condition and it can have a huge effect on people's quality of life. And really, I want people to be thinking about, what's your priority coming into this consultation? What bothers you the most about the eczema? Is it the itch? That means you can't sleep. Is it really affecting your quality of life? Or is it the appearance that you're extremely self-conscious? So really kind of think in your head, what, and oftentimes it is all these things, but think, what is the thing that bothers you about the eczema? And then what are your short and long-term goals? So, for instance, sometimes we see people in the clinic and they might have a very important event and they might have a wedding coming up or a holiday that they want to enjoy. So, their goal might be really that they need to get the eczema under control as quick as possible. And what can we do for that? Or alternatively, sometimes people, the eczema maybe is not affecting them as bad, but, they want to control it in the long term. And in those conditions, we can sometimes maybe consider a slower type of treatment. Another thing is in people that are of childbearing age, if you're planning to conceive or hoping to have a baby in the near future, that's important that we're aware of that, because sometimes the treatments that we plan will differ based on those goals. So, it's important to prepare questions and, have a real think about what are your worries with eczema? What are your concerns? Would you like further information about the treatment you are using at the moment? And would you like to know any other treatment options? So do you want to look into tablets and injections? And I suspect that many people who are here today do want to consider tablets and injections. So, be aware of what you might want to talk about during the consultation. And then what to bring. So it is always really helpful if you can bring all the current medicines you're on. It's important that we know exactly what they are and what doses they are. And almost equally as important, it's really helpful for us to know all the previous eczema treatments you have had. So have you had, what types of creams and ointments have you used? What types of tablets or injections have you used? And have you used other things, modalities such as phototherapy? And it is really useful as well. I know it's a lot of homework, but it's quite useful for us to know how long you did use them for, what did work, if it worked at all, and what didn't work. And equally, did you have any side effects or complications from any of these treatments? And then if patients people that do have multiple other kind of conditions or medical conditions, it is very useful, particularly if there's some complicated conditions, that you can bring in the contact details for the other specialties. So if we need to get in touch with them, we can do this easily. So what might you be asked during the appointment? So we'll obviously ask you a bit about your history of eczema. We'll ask very detailed questions, very possibly, really going through the timeline. So when did it start? How has it changed over time? We'll ask about past treatments, as I said, so creams or ointments, phototherapy, or tablets or injections. And we'll probably go into detail about what is triggering this eczema. So is there anything in the environment that you think is causing it to get worse? Are you concerned that any foods are making it worse? Does it get worse around stress? Does sunlight make it worse? Or do you find it gets worse in winter or summer? We will ask you, go into your medical history, and we will focus a bit on the conditions that can be kind of clumped together with eczema. So related conditions include asthma, hay fever, allergic eye disease, and food allergy. And then we'll also just do a more broad history, in particularly asking about things such as, do you have any personal history of cancer or any severe illnesses? We will ask you about alcohol and smoking, which I suppose happens at every doctor's appointment you'll go to, but we'll also really try to get into detail, hopefully, about the impact of eczema on your life. So how does it affect your sleep? Are you missing school? Are you missing work? And how it impacts on your mental health. And then, as I mentioned before, if you are of childbearing age, we will ask you about if there is any family planning considerations, as this could impact the choice of treatment. So what might happen during the consultation? So we are dermatologists and our job is to examine the skin. So we will assess your skin. We will probably ask you to get down to your underwear, and you might even look in some private areas if necessary. That is something that sometimes eczema has certain patterns, and we really want as broad a picture as possible. And we'll check for things like signs of infection. So we'll see if your skin is weepy or anything like that might require antibiotics. And sometimes people who have very flared eczema sometimes can get inflamed lymph nodes. So we will maybe check under your neck, in your armpits, and also in the groin area, just to see if we can feel any lumps or bumps. We do like to get an objective score of how severe the eczema is. So we do what's called an EASY, and this is a score in which we do to measure the eczema severity. And as you can see on the image on the right, we do a broad score of how much of your body surface area is affected, how red the areas are, how swollen or how much sweating there is in the area, if you've been scratching a lot, and also if the skin is thickened, which are all increasing signs of increased eczema severity. But as important as what we can see is important, it's also very important how it affects you. So we do two scores usually. One is a DLQI, which is a score about how much has the eczema affected your quality of life over the last week. And we also do a score which is called a POEM, and that kind of gets into more the nitty-gritty about what kind of symptoms are you feeling on a day-to-day basis. Either before or after you've seen the doctor, we might do certain other investigations. We'll often just do simple things like a blood pressure and a weight. And then depending on if we are thinking we might be going down the route of doing a tablet or injection, we might do blood tests. That's not always the case. For certain tablets or injections, we also sometimes consider doing a chest X-ray. And then we'll talk to you about the way you use treatments and different things. And if we feel maybe you could do a bit better with different regimes, we might bring you in to see a nurse who can talk to you about how to use different creams, ointments, and bandages and things along those lines. It depends on the center you're in, but if you do go to a big center of dermatology, sometimes there might be a research team who, if you are open to it, they can sometimes discuss if there's any other treatment options or new treatment options. And finally, dermatology is very visual, so we sometimes do like to take photos. So we might even arrange for you to get photos taken, and that can really help us guide when we see you again, see if treatments are working or not. So what are the potential treatment strategies coming from the clinic? So one is that, as I mentioned earlier, we might just arrange to optimize the treatment regime you're on already. So we might go through your creams, ointments, and dressings and give you a good regime and give you education on how to use them correctly. If things are particularly angry or flared, sometimes some dermatology departments can offer for people to come into the day unit, and they can come in over a period of time, or over a week or over weeks, and they can get intensive treatments with creams and ointments and more education as well. And sometimes that can really just help to give a break. Phototherapy is another option, which is like medicated UV light. It is a bit time consuming though, so people often might have to come in 2 to 3 times a week over a course of about 10 to 12 weeks if that's the option. And sometimes if we feel that the eczema might be caused by something in the environment, such as fragrances or metals or different types of things, we can arrange a thing called patch testing, which again, someone can come in over 3 times over a course of about a week and look to see if we can identify anything that could be making the eczema worse. But really failing that, or if those options don't suit, then it gets to I suppose, what is the key of today and what we want to talk about. And we might discuss different tablets and injections, which Dr. Pink will go into more detail in his talk. And then just a final thing prior to the presentation ending, the consultation ending, just to have these things in your head maybe before you leave. So just make sure you know what the treatment plan is and what the next steps are. If treatments have been suggested, we more than likely will give you information leaflets about these. So the British Association of Dermatologists have a lot of information leaflets about injections and tablets, but the National Eczema Society also have excellent information. So you could look at either resources yourselves even before the appointment. And then finally, the image there at the bottom is a contact card that we have in Guy's Hospital that we often give to patients. So So it's often good that that you know who to contact if things aren't working out the right way, and you know how to contact them. And then just make sure that you do have follow-up arranged, and there's a plan in place. So really, in summary, I think it's important to try to do a bit of preparation before you do go into the consultation to really maximize the consultation. It does help us, but also will make the whole process a lot more easier and streamlined if you can bring up-to-date medical information. And then always try your best, it's really on us, but to make sure that we leave you with a clear plan at the end of the consultation. So that's my slides, and we'll move on to the next topic.
Thanks very much, Len. I mean, I think the other thing is if you can bring somebody with you, it's good to have another pair of ears and eyes. And often I think there's an awful lot of information that we give, and it's difficult to take in. So yeah, bring an advocate, bring somebody with you if you can. But we can talk about all of that at the end. Thank you very much, Len. So I'm going to introduce now my colleague, Dr. Andrew Pink, who is a consultant dermatologist here. He runs our national specialised severe eczema service here at St John's. He's the director of our adult clinical trials unit and has been very intimately involved in many of the trials over the last 10 years that have brought all of these real step change in terms of treatment options that we have for people with eczema. And so I'm really delighted, Andrew, that you're going to give us a talk about this just now. Thank you.
Thank you, Catherine. Very kind introduction. And good evening all. I'm just going to get my running. Catherine, can I check with you? Can you see the full slide or can you see the preview screen?
Preview, so you need to switch.
No problem. Right, thank you. So good evening all. So my task tonight is to try and summarise some of the key facts around tablets and injection treatments for eczema. Now this is a very large subject, so I will admit up front that I can only cover so much in the next 10 or 15 minutes, but I want to really give an overview of what we have, and what some of the newcomers are, and how they work and what they offer. So these are some of my conflicts of interest. So I have worked as an investigator that finds or received educational research from some of the companies that make medicines. So this is quite topical this week, isn't it? Because the news headlines have all been around the return of the 2 astronauts that have been stuck up in space. Now I like this image in the context of atopic eczema because, as Catherine said, one of my big passions is trials. And you of all people don't need anyone to tell you about perhaps the lack of progress that there had been in the last 20 years in terms of therapies and therapeutics for eczema. But what's really been amazing in the last 8 to 10 years is that because we've suddenly had a greater understanding of what causes it, it has opened the door to new treatments. And it really feels like a bit of a lift-off moment, because suddenly we have treatments that are targeting very specific parts of the immune system that are important in eczema. And more important than all of that, those treatments have been known to work, both in trials and now in clinical practice. So the aim of this 10-minute overview is really to give a sense on what the tablet and injection treatments are. I'm going to spend particular time focusing on some of the newer treatments that have come through in the last 7 years, what they are, how they work, how effective they are, and to some extent how they compare. And I'm going to talk about a trial that we're running here, and explain the importance of that as we go through. So, as Len mentioned, there are steps that we take in the management of eczema. Now, these are general. Of course, the most important thing is that everyone is different. So every individual with eczema is different. And actually, there's a requirement to take a slightly different approach in everyone. And some things are appropriate, some things aren't. But essentially, when topical treatments have been tried or are not possible, and are not working, well, then we have other options. And some of those are phototherapy. So again, Dr. Timoney touched on this. the use of UV light to reduce inflammation in the skin. It's a 2 to 3 times a week treatment, usually for about 12 weeks. And it can give people a bit of short to medium term control. It's not a long term control of eczema, but it can get 12, 24 weeks of stability. And then we have systemic treatments that we've used over the last 20, 30 years. So these are tablet treatments. And the truth is that no one at the moment can predict who is going to respond to which treatment. And this is so frustrating for you, most importantly, but also for us. And we're doing a lot of research on this to try and be able to predict and personalize therapies, but we're not there yet. So some of the standard tablet treatments that we've used for a long time now are methotrexate, which is the most common first-line tablet treatment of choice for eczema in the UK for adults. That's a once-weekly tablet or injection. Cyclosporin, which is a once or twice daily tablet. Azathioprine, which is a once daily tablet. And less so now, really, mycophenolate mofetil, which is a once or twice daily tablet. So, so these are standard systemic treatments that we've used for some time. And over the last 7 or 8 years, we've seen the evolution of newer treatments. And these are coming in the form of both tablets and injections. And in the UK, through the National Institute of Health and Care Excellence guidance, which is funding and our ability to use treatments, we are allowed to prescribe these newer treatments in people if they have failed to respond to or are contraindicated to at least one of the standard treatment options. And as I said, I'm going to spend a little bit of time focusing on some of those treatments particularly. So before I do that, I wanted to just dip into the causes of eczema. And eczema is incredibly complicated. It's multifactorial. And if we start at the bottom of this slide, genetics, which underpin so much of what happens to us in our lives, are fundamentally important in eczema. And we know from the genetics studies that have been performed so far that changes in anything up to 100 different genes can have some impact on your risk of developing eczema. And what's really interesting is that a significant proportion of those genes relate to the immune system, and a significant proportion of those genes relate to the way that our skin barrier works. And it's that interaction between the immune system misfiring and the skin barrier not working in the way that it should that leads to the signs and symptoms of eczema. And at the top here, this orange box, again, you're all too familiar with this, but the environment, everything around us, further interacts with that. So if your skin barrier is not working and your immune system is misfiring, things in the environment, whether that's irritants, allergens, hard water, soft water, it can all have an impact on the state of your eczema. And a lot of the time, it's entirely unexplainable. And acute flares will happen with no clear cause because it's so complex in its origins and the elements that drive it. But the key point, I think, right now is that in terms of systemic therapies, the way that we can improve eczema is by targeting the dysfunction immune system. So it's targeting that immune dysregulation. We don't have effective ways over simple moisturizers of rectifying changes in the skin barrier directly, but we can improve the skin barrier by targeting the immune system, and that's important to say. So systemic therapies that have come through. So this is almost like a target board. Imagine we're doing archery here. In the middle, these are the drugs that have now come through and are usable in the NHS to treat eczema, moderate to severe eczema in adults. So we've got 3 injection treatments, which is dupilumab, tralokinumab, lebrikizumab, and we've got 3 tablet treatments, baricitinib, abrocitinib, and upadacitinib. And I've put some further treatments in orange for tablets and yellow for injections, just showing you that there is an awful lot more coming down the track. Now, some of those are in early phase trials, so they may be 5 to 7 years out from realistically coming into clinic, but some of those are in later phase trials and may well come through to clinic in the next 3 or 4 years. So multiple treatments have recently been approved, and there are lots more coming. And interestingly, of the ones coming, many of those have totally different mechanisms of action to the ones in the middle of this circle, which is important because the unmet need in eczema is still very significant despite these new treatments. So having new mechanisms of action very important. So if we now focus in on these new treatments that came through just a moment, but before I do, I wanted to mention that it's not just tablets and injections that are improving in the space of research in eczema. There are also highly effective new creams and ointments coming through that are not steroid related, which is another important development, especially for localized disease. So these are the injections and the new tablets, and to try and explain a little bit how they work. So this is a picture of the skin. If we take a sample of your skin and look under the microscope, what you should see is a top layer that looks almost like layers of bricks, and under that a nice light pink layer that you can see in the bottom half of that circle that shouldn't really have any purple dots in it at all. Now in eczema, you have this flood of inflammatory cells. So white blood cells come into the skin, and that's what you're seeing here as the purple dot, and they release their inflammatory signals, and they cause the redness, the itching, everything that we know in eczema. And if we zoom into that cell, so if imagine we've got the cell here, we've got the wall of the cell, and on these cells sit receptors, and there are tiny inflammatory signals in the immune system that come in, they bind to that receptor that sits on the cell wall, and then they cause activation downstream inside the cell, which causes inflammation and eczema. And so to understand where these new treatments work, how they work, well, they actually work in slightly different ways. So the injection treatments they're antibodies. So just like we develop in our body antibody treatments, we develop antibodies to infections, so viruses, bacteria, you can engineer antibodies in the laboratory to target any signal outside of a cell. So these antibody treatments have been engineered to target very specific inflammatory signals that are important in it. And for example, tralokinumab and nebrikizumab, you can see at the top there, they bind directly to one of the most important inflammatory signals in eczema, which is called interleukin-13. Dupilumab, which has been around the longest of these injections, actually binds to the receptor, and then JAK inhibitors, so the tablets, baricitinib, abrocitinib, and upadacitinib, they bind to this. You see these blue circles, JAK written in them. These are absolutely integral to the whole receptor working and the signal going down into the cell. So without the inflammatory signal, an effective receptor, or these two JAK blocks, you get no signal. So all of these drugs effectively block this cell activation and prevent the inflammation and the development or the propagation of eczema. So I hope that gives some idea of how they're working and where they're working. Now, how do we know how effective they are? Well, there have been lots of clinical trials done certainly over the last 10 years with the novel treatments, less so with some of the older treatments. So there is data, but there's not the same amount of data for the older treatments as we now have for the newer treatments. And this is a really helpful resource. This is eczematherapies.com. You can see the website address at the bottom. And it's done in a really nice way to understand, or get some idea of how these drugs work at 8 to 16 weeks. And it's important to say that these drugs all work at different times. Some of them work very fast, some of them take a bit longer. And so actually, if you cut down at 8 to 16 weeks, it's not necessarily showing the best of all of these treatments. Injection treatments, for example, take a bit longer than some of the other tablets. But this website gives an idea of what you can expect in terms of the improvement in itch, quality of life, and the appearance of the eczema. So here you can see cyclosporin and the trexate. Here you can see dupilumab and tralokinumab, and this is not direct comparison. This is just using indirect data from available trials, studies that have been run with these medicines. And here you can see JAK inhibitors, and you'll see that there are slight differences in the itch, quality of life, rash improvement that you might expect with the different drugs. But it is with that caveat that if you move the finish line, and I like this cartoon as one of mine, because if you move the finish line, you would see a very different readout of results for these medicines. So coming back to Dr. Timoney's talk, having a realistic expectation of when you might expect to see improvements and when you might expect to see the maximum improvement in these drugs is important. A couple of examples just to demonstrate, and thank you to the patients who finally consented to us using photos that demonstrate improvements. This was a patient on a JAK inhibitor, one of the tablet treatments, and you can see a very rapid improvement in signs of eczema, and indeed the symptoms match that. And similarly, this is another example of a person on one of the injection treatments. So tralokinumab at the start of treatment, a lot of redness and inflammation, and 6 months, very, very clear skin, actually, very impaired skin. So the question is, which treatment do you use for which patient? And there are a few things that we consider. So some of these treatments work for things other than eczema. And so if you have other diseases that these drugs work for, we may lean towards one over another. So an example of that is dupilumab. So dupilumab can treat other atopic conditions. And what we mean by atopic conditions is things like asthma, hay fever, and nasal polyposis. But as with all medicines, these new treatments also have some side effects and niggles. So dupilumab can cause a little bit of irritation in the eyes, around a third of patients. Rarely, about 1 in 20 patients can get some rash on the face that perhaps they didn't have treatment. And again, rarely, about 1 in 20 patients can experience some element of joint pain. Dupilumab, by the way, works at maximum at about 6 months onwards. It works quite quickly. You'll notice the difference in the first 6 to 8 weeks, but it really hits peak effect in 6 months. Tralokinumab, lebrikizumab. So these are, again, injection treatments that we've spoken about. They may carry a slightly reduced risk of conjunctivitis and facial rashes and joint pains. And I can only say may because that's from the trial data. They haven't been in use in real-world practice as long as dupilumab. So we don't know that yet. So time will tell on those treatments. And again, they take time to work. So maximum effects 6 months, but expect to see results, things happening 4 to 8. And then the JAK inhibitors. So these are fast-acting drugs. These work within 4 to 8 weeks. So they are faster than the injection treatments. And if people are in a flare and they need rapid improvement, it might be a reason why you lean towards one of these perhaps rather than injection at a particular point. And they work for other conditions that are quite different to the ones that I mentioned with dupilumab. So they work for conditions like autoimmune hair loss, vitiligo, which is a pigmentary change in the skin, and inflammatory bowel disease like ulcerative colitis, Crohn's disease. But they also have side effects, and because their mechanism of action is a little bit broader than the injection treatments, because that blue JAK block that I showed you in the cell is relevant not only to the signaling in eczema, but also to some other functions in the body, they do have slightly more side effects than therapy. And the main ones that we tend to see are infections, and that's cold sore virus and shingles, types, stomach upset, acne in a proportion of patients, around 10%, headache, and sometimes blood test changes. Slightly more side effects than the injection. And the truth is that some of these drugs will fit a certain individual and not another. But the big problem we have right now is we don't know how they directly compare with one another. So to very briefly finish, I'm going to just introduce the Beacon trial, which is a trial running around the UK at the moment, the best systemic treatment for adults with atopic eczema. And I've put a picture here of the caucus racing because the situation is when a new drug comes along, the trials that are set up for that drug don't necessarily correspond with the trials that have been done with another drug. So it's almost like every drug is running its own race. It reads out its response at a different time point, and its response readout might be slightly different from a trial with the drug next door, which means it's very hard to know how they directly compare. So the aim of Beacon is to ask, actually, how do these drugs compare head-to-head, giving them the time to perform optimally. How do the new drugs compare against the ones we've used for a long time? We honestly don't know that. And should we use them in the pathway? How well do the drugs work and how well are they tolerated in real-world populations? So in trials, you have very select criteria for who can go in and who is excluded. So we're trying to give a bit more of an answer in terms of real-world populations. And which of the medicines represent good value for our NHS? So the key question is, what is the most effective, tolerable, and cost-effective systemic therapy to treat severe eczema in adults? It's for adults with moderate to severe eczema who need systemic treatment. That's the population that we're looking at in Beacon. And we have 4 treatments being studied. So cyclosporin, methotrexate, dupilumab, and abrocitinib. So 2 of the standard systemics there, and 2 of the novel treatments. And it's a 1-year trial. We started recruiting in January, and we are planning to have 24 sites open around the UK. You can see where we've got sites open or about to be open on the right here. So green is open, amber is expecting in the next month or 2. So we're getting good representation around the UK now. And what Beacon involves, very simply, is it's based on NHS practice. So for anyone that goes into Beacon, they are randomly assigned to one of the 4 treatments, and there is no placebo. Patients know which drug they are on. There are 6 visits across 1 year, some safety visits for the drug that they're randomly. And for some of the medicines, you're able to increase the dose 3 months, just as you would in the normal clinic. So that applies to cyclosporin and methotrexate. And then if the drug is working, you continue up to a year. If it's not working well enough, well, then there's the option to switch treatment, again, just as we would in real-world practice. So people on methotrexate or cyclosporin in the first 6 months, and you can use topical treatments throughout the trial. And one exciting thing about Beacon is that it is innovative in that trial designs over the years have changed. So trials used to be set up with 2 arms or 3 arms, 2 different drugs, 3 different drugs, and they run and they close. Whereas over recent years, and there are 2 examples here, one in prostate cancer called Stampede, and one here called Recovery, which many of you will have heard about COVID, you can now run trials where you can add drugs in over time. So as new drugs come in for a disease, you can keep adding them into the trial, which means you have a much more efficient trial to look at the effects of new medicines and to get an idea of how they compare with the medicine you're already using. And Beacon is one of these types of trials called a platform trial. So we hope that as new treatments come through in the future, we can add them into the Beacon trial. It will give us some idea of how these drugs can directly compare and what we should be using for the patients. So in summary, there are lots of tablet and injection treatments for moderate to severe eczema. Some of them we've used for a long time, some of them are more recent, such as the injection treatments and the JAK inhibitor tablet treatments. We certainly need to know how these treatments compare with each other. That includes how the new ones compare with the old ones to inform our practice. And we hope that Beacon will provide some of that data to highlight more effectively going forward. If anyone is interested in Beacon, then there's the website, so please do have a look and contact us. Thank you. Catherine, I'm going to hand back to you, but I mentioned
Thank you very much, Andrew, for a great talk, and you've covered an awful lot. I suppose the thing that has come out from your talk, and also from all the streams of questions coming through the chat or Q&A panel, is that people are, can you put that slide? Yes, people are asking, why do they have to have systemic therapy, old ones versus the new ones? When should they be using them, how long for, and so on. And these are such important questions. So one of the clear unmet needs at the moment is that we know that people who really would benefit from systemic therapies, both the new and the old, aren't getting in to see dermatologists quickly enough, early enough. One of the things that we've been working on over the last 5 years is trying to understand why eczema progresses, who's at risk of getting more difficult, problematic disease. And that's been the focus of a thing that I've been involved in Biomap across the whole of Europe. And we're running a webinar on next week, next Tuesday, on what we're finding out. So please do register and join that. The National Eczema Society have been partners in this European consortium. But what we're doing is also thinking about what we've learned in Biomap and how can we use it for the next stage. And so this is where this interactive poll we're going to run now. So you can take that down, Andrew, and we can go on to our we get our audience to do a little bit of work. Hopefully you've all logged into the menti.com, I'm hoping. And if you haven't, you scan the QR code, and when you scan it, you should come to a website where there's a little blue thumb that says that you're on the system. That's great. I can see lots of thumbs arriving. And then if we go to the first question, so this is about trying to understand how difficult it's been or easy for you to get to the treatment, whatever it is, if quickly and effectively. How many of you have found that difficult? So that's yeah, unfortunately often the case. And we know that our systems and the current treatment pathways generally require people to go and see their GP or a non-specialist. They may go backwards and forwards for treatment in primary care, and then it reaches an eventual threshold where you might get referred in. And we are interested to see whether or not you could do it in a different way. And one of the ways is trying to better capture the activity of eczema from the patient's point of view, and what their eczema is like, what the burden of it is, using digital health technologies. And we know that how your eczema looks, for example, on the day you come to clinic isn't necessarily indicating really how it's been over the weeks or months. You know, it comes and it goes. And so we're interested in finding out whether we can use digital technologies and really pull in the patient to become the person who says, okay, I'm putting this information in, and that then says, okay, yeah, you need systemic therapy. So if we go to the next question, it's really about how much, if we were developing digital technologies, you know, download an app, how comfortable people might be to give information about their skin. This would obviously be in a very secure environment, but nevertheless, it's sharing and photos or other information with the view of then getting feedback on, for you, what might be treatment recommendations, evidence-based, and maybe even direct access to care. So that's very interesting. So it seems that from this, most, but there are some people who would have reservations. So we need to, the plan is to do some more detailed work to try and understand how acceptable and what people feel, and whether we can really address those. So that's very, very useful. And I don't know whether there's one other question. This is really to try and understand what it's been like for you to get to the right treatment. Anything, any words there, just tap them in. And the words, the more people who put in words in a theme, then the words get bigger. So the larger capital words. So there are some pleased, but mostly those are incredibly being testimony really to what we need to try and do much better. Well, thank you very much, everybody. And it's very powerful and motivating, honestly, to try and address this. So shall we, thank you very much. I think we'll, just because I want to make sure we do have some time for addressing the question. So I'm really happy to bring back our two speakers, Andrew and Len, but also to invite and welcome Sarah Copperwheat. She's the lead nurse prescriber in Sussex Community Dermatology Service, and she's got an MSc in clinical dermatology, and she is very involved in monitoring patients on these systemic therapies. So thank you for joining us, Sarah. And also then, as I mentioned, Dr. Cathal O'Connor, who is a consultant dermatologist and also paediatrician, so he's dual trained. So and is also very focused on atopic dermatitis. And then Andrew Proctor, welcome, the CEO of the National Eczema Society. So I think I've got everybody. I've introduced everybody on the panel, I think. So we have got a whole stack of questions. Shall we start with some of these pertinent questions around systemic therapies, perhaps? Risk of DUPI, the biologics versus JAKs, JAK inhibitors. I don't know, Andrew, and maybe we get Cathal's opinion as well.
Yeah.
Get to the meat of it straight away.
Yeah, a good question. So I think with these new treatments, they're very targeted, and we have come across some side effects that perhaps wouldn't have been expected at the outset before these medicines came in. And on the injection treatment, so dupilumab, for example, the eye inflammation that I mentioned wasn't expected. Now, on the most part, is treatable with eye drops and sometimes the need for some eye specialist input. As I say, rarely you can get some worsening of facial eczema, and rarely you can get some joint pains. So that's dupilumab. The JAK inhibitors that have quite a different profile. So as I mentioned, because they have a slightly broader impact on the immune system, dupilumab targets 2 tiny signals in the immune system, and the JAK inhibitors really pick off more than that. They're almost somewhere between a cyclosporin and dupilumab, if you like. They do increase the risk of infection. So cold sore virus and shingles are 2 things that we certainly do see with JAK inhibitors. But you can get niggles, so stomach side effects, a little bit of nausea, a little bit of acne. There are some much rarer side effects. So we're talking about in the region of, if around 400 patients JAK inhibitor for a year, you might expect to see 1 clot. So there is a rare risk of clotting, DVTs or pulmonary emboli with JAK inhibitors. So all these medicines carry different benefits, but also different risks. And it all comes down to the individual and really you understanding those and weighing them up with our help to decide what the best path is for you at any one time, I think.
We need to understand in different people which pathways are particularly active, because that will then mean that certain drugs are predictably going to work better than others. But that is all research. Cathal, do you have anything there to add in terms of what Andrew said? It's a big question, so we probably could spend the rest of the session talking about it, but we're not going to do that.
Yeah, and I don't think I've seen much eye side effects really. I think at the start when dupilumab came out first, we were seeing it a lot more because I think we were starting it in our most severe patients, patients with most severe eczema. So I haven't seen it recently. And it tends to be quite mild, and we have a nice algorithm for managing it if it does happen now. So dupilumab is very safe. It's quite life-changing for a lot of people. So I think people are delighted to get access to it when they can.
Yeah, no, I think that's very true. Sarah, do you have any comments, monitoring these treatments in your setting, or are you not using these very new ones? Anything from a patient, your perspective, supporting people?
The dupilumab we do use. We've had a few of the eye issues, but we have to say I haven't seen as much recently. But the JAKs we haven't used as much in eczema at the moment, sort of just coming through a bit more in our service. But yeah, the patients, the monitoring of biologics compared to systemics, from a patient perspective, I think is easier with the biologics.
Yes, I mean, that's a big thing, isn't it? There's a lot less blood testing and frequency of blood testing. So one of the themes also is there's lots of questions about coming off these medicines. So when people are doing really well or clear skin, how do they taper it? I think, I will say we're doing a lot of research around this, and this is going to be one of the themes going forward about how we minimize drug and can we understand who's actually gone into complete disease resolution and potentially stop their therapy. So again, watch the Biomat webinar. There's lots about it there. But Andrew, what and any comments about you know, in clinic now, how to approach tapering. There's lots of concerns about rebound when you stop, and so on. Oh, you're quiet.
Can you hear me?
Yeah.
Yeah.
Now we.
When somebody's on anything that's modifying the immune system, we want them to be on the least that they need that does the job. And so once you have a period of stability, and I think it is important to get 6 to 12 months of really good skin stability before you start necessarily trying to reduce dose too much, then I think it's a good time to start trying to down titrate, finding where that threshold is. And there's no doubt that some people need a lot less drug than others. And also, it's well shown in the trials that some people get really long periods of remission of drug after having drug for 6 to 12 months. And that's something, as Catherine said, we're really interested in exploring.
Yeah. Any comments from a paediatric point of view, Cathal? What's your experience of these new drugs in kids?
Yeah, it's a very interesting point. I would say in pediatrics is a little bit different from adults. The immune profile, so the types of, you know, immune abnormalities are a little bit different. It's a more chronic or long-term process in adults, and I think it is probably a little bit more reversible in children. We did a nice study in Ireland and the UK called the TREAT trial, which looked at methotrexate versus cyclosporin in children, and it showed cyclosporin was better initially, as Dr. Pink showed, but methotrexate was better after 6 months. But the interesting thing in this study was that after 6 months, all medications were stopped, and with methotrexate, the benefit was continued. So if they were 70% better, they maintained that 70% improvement. You know, obviously people can relapse, but I think eczema is a little bit different to other inflammatory skin conditions like psoriasis, for example, where we can switch it off. I don't like using the word cure, but I think long-term remission is the term that we can kind of use. You know, we can get the eczema into long-term remission where you don't need to use many creams and just have a treatment that you take once a week or once every 2 weeks, which is a very low burden of treatment for patients and families.
Yeah. No, well, I think that is a crucial question. Is there a point at which you can intervene that would then give longer term chances of remission? I would be actually maybe psoriasis as well, but we'll see. I think Len, there's a few questions here about Len, and maybe also let's get Andy to answer this question first. How can I get an appointment with a dermatologist who offers other solutions other than steroids? I've been referred to dermatologists in the past who've just given steroids. Help.
I think anyone whose eczema isn't being well controlled with the help and support for their GP should get a referral to see a dermatologist. So that's it within the NHS system. Unfortunately, it can take a long time to get that referral. And then when you get to see the dermatologist, your eligibility for some of these newer treatments is also restricted in terms of you've had to have tried other immunosuppressant treatments like methotrexate or cyclosporin before you're offered one of these newer treatments. So it can be a long journey for some people, but it tends to be the bigger hospitals, the bigger centers that have used some of these newer treatments more just because they are new. So I think anyone who is getting a referral in to see a dermatologist can contact that hospital and ask them what treatment options are available, just to get a sense of what will be available when their referral comes through.
Yeah. It is obviously very frustrating, and that actually evidenced by that word cloud. And it's frustrating for us actually as well when we're seeing people who've had such a difficult time getting to see it. I mean, you can self-refer to Beacon, by the way. Andrew, there's a question here about the Beacon trial and what happens at the end of the year.
Yeah. So you're absolutely right, Catherine. You can self-refer to Beacon. So if you go to the website, it's all on there. If you're interested, I'll send you more information at the end of the year. So if you come in and you're randomised to methotrexate or cyclosporin, and you carry on through the trial and you do well on that for 12 months, well, at the end you can carry on those treatments in the NHS. If you come in and you're randomised to, for example, dupilumab or abrocitinib, and you stay on those throughout the whole 12 months, it will, at the end of the trial, it will depend on how you've got on the medicine and whether you meet the NICE criteria to continue you on those treatments after the trial, and you may well, if you're contraindicated, to one of the standard systemics. So it's a discussion at that point really with the trial doctor at that stage to determine what the best route forward is.
Okay, thank you. Cathal, there's a question here for young children with eczema. Are topical steroids still considered the first line of treatment?
Yes, yes, definitely. So for mild to moderate eczema, topical anti-inflammatory therapy is definitely first line. I would have a low threshold for starting methotrexate though for moderate to severe disease. So creams are great and they're really safe, but some people's eczema is too severe. And the creams are not strong enough. And in dermatology in general, we use ladders of treatment. So topicals are the safest, most targeted ways to deliver therapy to the skin. We're very lucky in dermatology that the skin is such an accessible organ. So topical anti-inflammatory therapy is a very elegant way to deliver anti-inflammatory therapy without any side effects that you would get with tablets or injections. So it's really nice. I think other specialties are jealous that we can apply things directly to our organ of interest. So definitely they have a huge role to play. And in particular, I would say in early life, we can definitely switch off eczema just with topical therapies if we get in early enough. But then if the burden is becoming too high with too frequent use of creams, that's where I think patients see a big benefit with systemic therapies like methotrexate or dupilumab. That's one of the things I say to patients actually, that, you know, you'll be needing a lot less creams in 3 or 4 months.
Yeah, I think it's right, isn't it? That threshold, and I think it's a combination of access to dermatologists, where the problem sometimes comes into. So as you say, people with moderate to severe disease really probably need more. Your note about a low threshold for methotrexate, for example. There's some questions here about use or what any 5% urea cream is helpful, Sarah, for this person, and it reduces inflammation. Is it okay to use in the longer term?
Yeah, emollients such as the moisturizers, even with the urea in, are absolutely fine for long-term use. Some people do find them a little bit too occlusive, as in a bit too heavy. So especially in the summer, when you're sweating and the skin can't breathe quite as well. So it's just keeping an eye on that, and perhaps just using urea when you know you really need to, and perhaps moving to something a bit lighter if you can. But there's no harm with long-term use of that.
Do you have a favoured best cream to use on very dry skin? It's a big question.
It's a big question,
perhaps
and
you can't answer that.
And I'm not sure. Yeah, I'm not sure that there's many products out there with 25% like Flexitol. Then you've got Balneum and others, so that are available.
Yeah. It's very individual, isn't it?
Yeah.
It's you like really, and pushing with your GP to try something different if it doesn't suit you, I think is really important.
Yeah. And knowing that you're entitled to get your moisturizers on prescription if you have a diagnosis of eczema as well. So it's just knowing what you can and can't have. Yeah.
Yeah. And then finally, treatments for pregnant women. Who would like to answer that? Len or Cathal? Cathal, maybe, Cathal, because you're a pediatrician. Yeah. You're going to be looking after all the healthy babies.
Exactly. And so methotrexate cannot be used, and I always have to be careful with this. It can be, but it should not be used for pregnant women. It causes very severe birth defects, so methotrexate is an absolute no-no, and we advise patients who could get pregnant that's a real huge risk. So methotrexate definitely not. Cyclosporin is useful in pregnancy, and eczema often gets worse in pregnancy. So our women's immune systems changes during pregnancy to accommodate the father's genetic contribution, and that produces a kind of an eczema exacerbation, where some people can get eczema for the first time. So cyclosporin is a good conventional immunomodulatory agent. in terms of biologics, they are very safe. So dupilumab is very, very safe. And actually biologics don't cross through to the baby until the 3rd trimester because they're very big molecules. That's why they have to be injected. It's a bit like people who have diabetes and have to take insulin. They have to inject it because it would just get digested through their tummy. So biologics are very, very safe. There's no issues for the baby after birth, even if the mother continues to take it. And dupilumab is now licensed down to 6 months of age, so it's it's safe to give it to babies. JAK inhibitors are not safe to use in pregnancy as well, so I would say it's kind of cyclosporin to dupilumab. Yeah.
Okay, thank you very much. And then Len, finally, what do you say to your patients who are on these systemic therapies about topicals? Is it okay to carry on with topicals, or
Yeah.
is there any concerns?
No, I think continue on as you've been doing already. So, for instance, sometimes dupilumab or whatever other treatment will do a great deal. It'll do most of the work, but if you're still getting inflamed skin, you're still itchy, still not feeling good, absolutely use topicals as you would have in the past. And sometimes the dupilumab has just helped that bit that you need a lot less steroid to get things under control.
And I think it's true of systemic therapy generally. It's important actually sometimes to continue with topical agents, because although these new treatments are incredibly good, they aren't perfect or brilliant for everyone. I think. I mean, there's still need for. So I think that is important. I think that these new treatments are definitely, as Cathal said, life-changing. Certainly for some people, but still, as indicated by the questions, sometimes they don't work, sometimes they don't. So there's lots of room to continue the research, and that's the exciting thing. There really are lots of new drugs coming down the pipeline, and new approaches as well. I think we've talked a lot about drugs, but there's a lot of research going on around lifestyle, how we can modulate the microbiome, all of these other aspects to eczema that are so important, but that's probably for another day. So I think we should finish then. Thank you so much to our speakers. There is a feedback, and please do give us feedback because it's vital to try and make these sessions useful for you. So the next slide, asking you, do you better understand the treatment options for more severe eczema after attending today's webinar? This is really immediate feedback. It's feel like you're getting marked on your homework, Andy. Does this keep running, or is this the final option with this?
I think maybe go on to the next question.
Next question, please.
Yeah.
Okay. So how much do you feel you've learned from today's? A great deal of new information. I learned a moderate. I learned only a few new points. I did not learn anything new. Not sure, not applicable. We've got some well-educated individuals in the audience. Would you recommend one of our webinars to someone else? Option to feedback additional detail, Andy, on this.
I think there's going to be a survey going out to people who attended today at some point. So if you're able to fill that one in, that'd be fantastic.
Yeah, please. Sorry, Len.
Don't mind. We do have a few more slides as well, just for links. There are some more with regards to the previous poll where there are some questions about research. We do have some more detailed questions, which we think would be really useful if people could answer them. That'd be really helpful.
Yeah, it's about a research program about kind of enabling earlier, more effective intervention, what the barriers and enablers are, and understanding what your priorities are. So please do fill that in. And just again, to thank you everybody for participating, our speakers, but also you, the audience. Have a lovely evening. Thank you very much.